Hey there. Welcome to the Pelvis Project podcast. I'm Megan.
And I'm Roxy. We're two pelvic health experts brought together by passion for our careers, entrepreneurship, motherhood, and the desire for intentional relationships.
Join us in our mission to spread pelvic floor awareness and start conversations surrounding the truth behind genuine health, imperfect wellness, and joyfully navigating life. We are so glad you are here with us.
Let's start the conversation. Hey, here we are.
Hey there, 9:40.
No place
Pelvis
I'd
Project
rather
After
be.
Dark. I know. Well, didn't help that we were just on for an
A long
hour
time.
talking about our business woes. Listen, everybody, if you think entrepreneurship is easy, it is not. But we wouldn't have it any other way. And we have each other.
And we wouldn't have it with anybody else. Yeah,
That's right.
Yeah. Okay, well, tonight we are coming at you with a kind of a fun topic that's not fun for our patients, but it can be an exciting experience when people look back on just the progress they can make. We're going to talk about prolapse, everybody, and that's a scary word, but it doesn't have to be a scary reality. And so before we do that, we're going to do our ever faithful, tell me something good, Megan, blindsiding you mildly with that.
That's right. Oh, well, you're catching me on the day after I had not something very good. And that was that we had to say goodbye to one of our beloved dogs. And so it's been sad days. But in the midst of that, we just got through Thanksgiving, obviously, and got through it. It was great. I'm glad we had it. Man, I'm really struggling this time because not last week, but it was like the week before, I had food poisoning and I was just
struggle bus.
I had a lot of like some struggle bus dumpster fire. But no, Thanksgiving was really great. It was a well-needed break, like just from work and my brain, thinking of all the things, and the kids were off of school for a week. It was just really nice to unplug and have some time together. And my husband and I had a good date night, had my birthday over that time. And yeah, just really thankful to be able to slow down. Like it felt really good. And then back at it this week. So what about you, Rox?
Well, I'm just going to shout out to my husband because this guy has been great and maddening all in one. I say that with lots of love, in that he is a very avid bow hunting gear, right? Like, and I gotta love it. Like, if I could go sit in a tree stand for evenings on end, for hours in the silence and the nature, I would love this hobby too, right? Like, what am I doing? I'm the idiot here, right? But no, I get to like have the girls, which I should be so thankful for, but just like basically single parenting for a season. Anyway, it's not that bad, but he got his deer. He's been watching him.
Good.
He's been like so committed. He didn't do any cameras this year. He just wanted to kind of do it. I don't know what it's called, all natural, not really, but like old-fashioned way, I guess. Anyway, he's just been watching this stinking deer. This deer's kind of smart, evidently, because he'd sit in one stand and the deer would go on the other side, right next to his other stand. And then the next night he'd switch. And anyway, well, he finally got him tonight. And so I'm just kind of proud of him. And
how many hours would he go and sit in these stands?
Oh my gosh. Like he would go at evening, puts them to bed. Like he would go, he'd go after work and then it'd be dark, a couple of hours each night, 3 or 4 maybe.
You go and sit and just wait.
You go and sit and wait. You watch them. Yep.
I just didn't grow up hunting, so it all just sounds so interesting to me.
Well, I ask really dumb questions sometimes. Like one night he didn't go and I was like, oh, why? He's like, oh, the wind's not right.
Oh my.
Oh, like because they'll smell him. Yeah, like they smell him. So I don't know.
Oh.
Yeah. Like if either downwind or whatever. Yeah.
Gosh.
So it's a whole nother world.
Yeah, I guess
I'm
so.
grateful.
But
I have my husband back.
Yeah, no kidding. He got the deer. That obviously it's deer season. And we were driving home on Saturday from my in-laws' house. so we like always go the same way home. But this particular night, Nathan went straight instead of turning where we typically turn. And the reason why he did that was because we were all in the car and there is an intersection that we have to turn left on by our house. And it is known to have a lot of car accidents. And my son actually will request us to go a different way because he knows this about this intersection and he does not like it. It's one of his things that we have worked on with, just anxiety and all those things. He was just being nice and he was like, okay, I'm just going to go straight. Not that he wasn't not nice, not doing it, but like he didn't even say anything. Yeah. He just did it. And so we were just driving along and it was dark. Wichita, it's out on Greenwich. And so all of a sudden he like slams on his brakes and this huge buck was just moseying slowly across the street. And he had to turn his brights off because there were cars coming. And had he had his brights on, he would have been able to see it better. And I literally was just like, I don't know how you saw that. Like, I don't think I would have seen it. And he goes, well, he was like, I saw the silhouette for just a minute and then the way the light shined. But I mean, that thing was just not even running. It was just walking across the street, just waiting for a car to hit it. On. So anyway, it got across the street. Nobody hit the deer. But anyway, so. All right. Well, now that everybody's listened to our podcast about deer.
Yeah, we should just call it, my husband listens to deer hunting podcasts sometimes. So they are a thing. I mean, if Pelvic Health has a podcast, deer hunting has a podcast. So
that's so true. That's so true. All right.
Yeah, we'll get to the real nuts and bolts here of pelvic organ prolapse. So go ahead.
I was just going to say, I feel like pelvic organ prolapse or prolapse, everybody refers to it as, is like such like this, it feels like such a scary thing. It's like this mystery of, are my organs going to fall out? And that's like kind of this feeling that's going to happen, and to reassure you, like, no, that's not happening. But yeah, I think a lot of women are scared of prolapse, especially having a baby, postpartum. And then if you do have a prolapse, then there's this like weight that you carry around, like heaviness that like something's wrong with you, and almost like just grief over that your body's changed. And so hopefully just learning a little bit about prolapse can help like shine some light and know that, yes, in some situations it's hard. And that's where you have a therapist help navigate through learning and knowing how to help your body, appreciate your body for what it can do, different strategies that you can use. And there's some really great accounts out there that are physical therapists or occupational therapists that are pelvic health providers that are brilliant and know that's what the majority of what they treat. And so that's where I would highly recommend, if anybody's like trying to find resources, that you know who it is that you're learning from, and that it's not just like, not to diminish anybody's experience, but there's a difference between maybe somebody who happened to have a pregnancy and deliver a baby and not have a prolapse that now is selling some program that I can help you not have a prolapse, versus a doctor level degree and training and advanced training in prolapse and what they can do. So just know who you're learning from. But anyway, start us off, Rox.
Well, I think let's start out with just a quick definition of pelvic organ prolapse. We'll just call it prolapse, everybody. But that's, if you look it up, if you want to really like, the correct term is pelvic organ prolapse. But it's basically the descent or the protrusion of your pelvic organs. And that can be your bladder, your uterus, or your rectum into the vaginal canal. And sometimes ultimately the vaginal canal does come outside of the interior of your body. I think there's a lot of misconceptions that it's your bladder that's actually falling out. And in fact, your bladder can't get through your vagina, like just anatomically, that's impossible. So just kind of, that's a big misconception, like my bladder's falling out of me. Well, it's actually your bladder pushing onto your vaginal canal, and the canal kind of descends. But we name those as, you're going to hear other names for those, for a prolapse, like a cystocele, which is when the bladder pushes on the vaginal canal and then that protrudes closer or outside your body. You might hear of a rectocele. That's the exact same thing, except for it's coming from the posterior side, from the back. It's basically your rectum pushing forward into your vagina, into like the walls of your vagina. There can be uterine prolapse, which is just where like the uterus comes straight down. So nothing's really coming forward or backwards. It's just coming straight down, and the vaginal canal kind of inverts on itself. And then vaginal vault prolapse. And so basically, all of those are organs that are meant to be above the pelvic floor. So if the pelvic floor is the base, right? I want you to imagine that is the floor. Then these organs are meant to be suspended up above the pelvic floor. And so if they are passing onto the pelvic floor or close to the vaginal opening, then there's going to be a sensation of pressure. And so just kind of to orient yourself to think that the muscles are supposed to be underneath it. So when we cough and when we sneeze and when we laugh and whatnot, anatomically, the pelvic floor should lift and support those muscles that are above the pelvic floor. Just if you can kind of imagine that in your head, the pelvic floor should be under those. When they descend or they protrude outside of our body, then they become lower than the pelvic floor. And that's clearly a problem because that's not where they're supposed to be. Megan, anything to follow up or clarify? Because I may have just butchered that whole definition.
No. I was just going to say there can be there can be a urethral prolapse.
Yeah.
We actually, I mean, in our clinic, I haven't seen it too often, but that can happen. And then, yeah, like Roxy said, I mean, the organs that the muscle, like the organs are basically, we got to think about like connective tissue and all of that is super important, helps hold our organs where it needs to be. And yes, they need to be above the muscles. And so if they have had that descent and they're sitting on the pelvic floor muscles, when those muscles contract, the organs it's heavy and it's hard. And that's why you feel that heaviness too. So hopefully, I mean, without having a picture, we always have these really great images in the clinic. It's really helpful for people to see those, of like what it actually is. It kind of makes it a little less scary because knowledge is power of like, oh, okay, that's why I kind of feel that there. And that's why I feel that there. And one of the biggest things too to know is like, hey, if you suffer from chronic constipation, like very often we have people that have rectoceles and they just don't even know it. It's harder for the bowel to come out because it gets a little bit of a pocket because of where it kind of protrudes into the posterior wall of the vaginal canal, but definitely, manageable. So let's talk about risk factors that can potentially be a possible reason why maybe prolapse is developed, that sort of thing. So childbirth can be one of them, especially vaginal delivery, because of the pressure down on the pelvic floor. Doesn't mean it's going to happen. You might get prolapse even though you've had a C-section. Like that's not what we're saying or what anybody, like that's the hard thing about childbirth is you really just don't know what's going to happen with your body. You can do all the things to try to help. We know things that help prevent. And there's certain birth positions that can be helpful. If you already have a prolapse and you're having a second baby, there's some different things that we like to teach to try to help with supporting the pelvic floor. So childbirth can be a risk factor. Age and hormonal changes like menopause, perimenopause, we've talked about this before. It definitely can influence the connective tissue and the pelvic floor blood flow. And then chronic pressure or what we just talked about, constipation, heavy lifting. So if you are, oh gosh, you have a chronic cough, like if that's just, like COPD, stuff like that, where you're just coughing, it's pressure over and over and over and over again. That can eventually lead to an issue. And same thing if you have some sort of job where it's just heavy lifting and maybe you haven't been taught the right mechanics. And over the years, there's been a pressure issue that's happened that can definitely lead to potentially some pelvic floor prolapse symptoms. Genetics and family history could play a role into it. Prior pelvic surgeries could influence risk factors for prolapse. Lots of different reasons why. And, we often see that if you've had a baby, like, I mean, if you have had a child, you probably have like a grade 1 prolapse and you just don't know it because the grade 1 is so mild and it's in the vaginal canal. And so it doesn't even cause a problem. And often you wouldn't find out that so many of us would not know that we had a prolapse. And then like we went and had went to a pelvic floor course and had a pelvic exam done to us multiple times by other therapists and find out, oh yeah, you have a little bit of a prolapse. There's a little descent there. And it's nothing to, like freak out about. It's just like, oh, okay, cool. So now I know that I probably shouldn't get constipated because that's just going to cause more pressure and you have to bear down. And if I already have a mild prolapse, then I don't want to be causing something that could potentially increase my risk for a higher grade prolapse, if that makes sense.
Yeah. And I would just kind of speak into that because that was me at PF, wherever Megan and I met. Like we were doing this and we were like learning how to really hone in and like decipher that. And I had a grade 2 prolapse and I was borderline devastated. I was like, oh my gosh, I'm not healthy anymore. I'm not strong. Like, and I know better. Like I know better. So anyway, I just would like, if you're feeling that, or if you're like, oh my goodness, someone told me that. And I feel like a lot of times those are the calls we get of women saying, my OB or my gyne just like, I just had my PAP or whatever. And they said that I have a prolapse, like, and they're like freaking out. And I empathize with you on that of like, it's not a fun thing to have that label on yourself that you've given yourself or someone's given you. And so if you've been there or if you're there right now, my heart goes out to you because I was in the same boat. But I am here to tell you that it does get better and we can do a lot about it. And it isn't a death sentence and it's very manageable. Like I don't even know that I have one anymore. So, I mean, I don't feel it. So, just coming from a personal standpoint, I get it.
Like that's really great that you shared that and taking a moment to just be like, listen, like just because we are pelvic health providers does not mean that we are not immune to having the same feelings that anybody else does if it's something's related. I'm going to tell you, when anything related to our pelvic floor or like vulva, vagina, anything like that, we still have the same feelings, even though it's what we do every single day and we know better. But it's still that initial like, oh my gosh, now there's something I have to pay attention to.
Yeah.
And I know that too about myself I know that I suspect that mine is like a grade 1, like rectocele, because I just know that like I do better, like if I stay regular and all those things. And then there's been other things too have popped up where I'm just like, oh my gosh, I don't want to have to deal with this. You kidding me? Like, this is what I don't want to, but you like take a breath. Luckily, we are trained in this. We also work with other therapists within our clinics that then can treat us. And we do the things and we get through it. And it's okay. So just taking a minute to know that like all your feelings are valid. They are okay. And we're here to help. All right. So we talked about risk factors. Roxy, why don't you talk to us about signs and symptoms?
So there are lots of different signs and symptoms. And then there's sometimes some symptoms that we also associate with it that might not be. So first of all, is the main one that we hear is just like this feeling of heaviness or bulging down at the pelvic region. You're going to almost feel like there's pressure. Sometimes it feels like you're sitting like on a ball or like tissue's a little bit like pinchy or it's just not where it's supposed to be. It's like a heavy feeling. That's literally what it feels like. So if you're not sure and you feel a heaviness, that's 99% probably what it is, right? And so it's just this feeling of heaviness, bulging. And that is that tissue that is now resting on your pelvic floor. It's resting right at your vaginal opening. Point blank, that's what it is. Some other things, though, that maybe aren't as obvious or maybe people don't realize will also happen is like difficulty, like Megan hinted at difficulty with bowel movements. It can happen with urination. Essentially, it's not a straight shot down anymore. Like if there is bulging into the vaginal canal, then there's area there for accumulation or pocketing or in your bladder. If your bladder's sagging backwards, all of a sudden the funnel's not at the bottom anymore. It's kind of a little bit off to the side or there's a little pocket there. And so when you're sitting down, a little pool can happen. And then you stand up and all of a sudden your bladder's not empty like you thought it was. And so that can be frustrating. Or the same with bowel movements. Like instead of just going out like it's supposed to, it gets kind of caught or it kind of gets snagged or it goes into this little nook, for lack of a better word. That can be also a really big indicator. Maybe people aren't feeling the heaviness, but they're having this like voiding or bowel dysfunction that they don't understand. And that can be definitely a byproduct of this. Another thing that we notice too is pelvic pressure. We kind of talked about that, but also like a pain. A lot of times when people are having like painful intercourse or just like chronic pelvic pain, it's not usually from the prolapse itself. What we find is that there's a lot of tissue irritation. That tissue is meant to be internal. And so if it's resting against your underwear or it's being exposed to more air or more friction or more rubbing, then that's really uncomfortable. It's like chafing essentially. Like it just is annoying. Yeah, go ahead, Megan.
I was just gonna say, and those are those higher grade prolapses,
Yeah, that's
like
worse.
I say, who's listening, if you're not a provider, obviously, then there's different grades. So grade 1 and 2 are very mild. And it's, in the vaginal canal, you probably won't notice it as much unless somebody's doing an exam. And grade 3 or 4 is where you could potentially be seeing something at the opening. So that's where, like she's saying, the exposure to air and, like underwear, that kind of stuff is a higher level prolapse.
Another thing we can see is like sexual dysfunction or discomfort. If that tissue is bulging or it's displaced, then frictioning it in and out with intercourse can be really aggravating too. Or maybe intercourse is perfectly fine, but then afterwards people will say, oh, I just feel heaviness or pressure after I have sex. And it can be right away or sometimes even into the next day a little bit. You just know that you've had something happen there where normally you would just go on about your day. And then sometimes people see a visible bulge in the vagina. If they take a mirror down to their vulva, they can see, oh, that's not how that used to look. That is more severe cases. Like Megan said, it's when that tissue is closer to the opening or right at, coming outside the opening. Those are more severe cases. A lot of times you might be able to see this visible bulge when you're doing a self-exam if you like bear down and you see tissue coming closer to the opening. But that can just be it can be a little bit alarming because if you've ever taken a mirror to your vulva and it looks different than the last time, that's a little bit shocking. So just something to be aware of that can be the case.
And I think just with that, we've said this before in a previous podcast, but if you've not gotten a mirror, checked out your own vulva, do it because this is why you need to be able to look and be like, all right, so it's basically just like check-ins, basically like a skin check, of has there been any changes like we do on our skin? Are there any new moles, places I need to get checked out? So you want to check your skin of your vulva too, but also to be able to say, okay, that is different. That wasn't there before. And what do we need to do? Again, knowledge is power. And it makes you feel, then you're not sitting there like, I don't know, has that always been there? And then I just want to say something about bowel with a rectocele and a prolapse is a common sign or symptom that people do not realize can be associated with a little bit of a rectocele is like where they have to, sometimes this can be a constipation. Well, probably they're constipated too, but excessive, like feeling like you have to wipe and wipe and wipe and wipe that's where that little pocket of like bowel where it wants to come normally where it'll come all the way out. It's like, there's like, if you want to think about it as backflow or something, it doesn't quite clear all the way. And so then you feel like you have to wipe and wipe and wipe. And it's not uncommon too for females that like only a certain point in their cycle, they notice that because as hormones have changed, structure, there's that plumping and that just lovely time leading up to ovulation when everything is like functioning correctly is there. And then sometimes we have that shift in hormones. And maybe if you do have a mild prolapse, it's just there's more awareness of it. And that's when you can notice that. So that's that wiping, which gets really annoying for people. And I love it when like that just gets better where they're like, actually, no, it hasn't happened in a really long time. So
yeah,
that's a good one. But okay, so let's talk about diagnosis and assessment. So basically, a pelvic floor assessment is really kind of the way that we look at and grade pelvic organ prolapse. And, typically you'll go see your OBGYN and they'll do a pelvic exam and have you bear down and they will give you the grade. Pelvic floor therapists, PT or OT are trained also in how to assess for pelvic organ prolapse. That's taught to us in our training. And same kind of thing, like we do your pelvic floor assessment and we have you do different bearing down techniques. And then we are able to kind of give an assessment of how far we feel the descent and we are able to look at that. And then also too, something that probably doesn't happen within your OBGYN appointment, but as advanced providers in pelvic health, not every pelvic floor therapist will do this, also assess prolapse in standing, which is really awesome because you live your life in standing. So I have had somebody who had a very severe prolapse and I believed what she was telling me. She was laying on the table. We did a lot of work there, and it hides. Prolapse hides. Even when she would bear down, like it definitely was there, but it wasn't extreme. And then I stood her up and we did an assessment in standing. And oh my goodness, it was one of those that I was like, okay, no wonder we're still having XYZ. So here's a referral. I want you to go see a urogynecologist and let's have a talk about a pessary, which we can talk about briefly. That would be like a whole conversation, which we should have somebody come on here and talk about pessaries. Cause like we can talk about them, but we haven't done the train. Like,
Yeah.
like we have therapists, friends who have done all the training on them. So it's really cool. So yeah, so that's kind of like how we would assess. And then in some situations, maybe, I mean, I haven't had anybody that's had to have any imaging done or anything like that. And I think in some cases too, there's like pelvic ultrasounds that could be done if they're just verifying certain aspects. But yeah, that's really kind of how that assessment goes. But with that, there are different treatment options. Oxy, do you want to go into that?
I sure can. So with treatment options, there's always, at the end of the day, if your organs are hanging outside of you, pelvic floor therapy can help with the outcomes of the surgery. It can help with optimizing mechanics, but that's not going to suck your organs back inside of you. Like we're just going to point blank.
We cannot
not going to lay
that.
claim to anything like that. But I will advocate that the treatment options we're going to talk about here, I think are still very necessary, but they aren't going to fix your problem. So,
well, hold on. Let's back up. If you're grade 1 or 2, they most definitely can be they can fix your problems.
They're not going to fix your problems if your organs are hanging outside of you.
Yeah. So like if you are looking at your vulva and you're like, oh my gosh, I see the bulge, like it's my bladder or whatever it is. If you can see it at the opening or it's coming, out, that is where we're like, okay, we need to get another provider involved in this of a urogynecologist. And then we are here as the support to help with the outcomes.
Yes. Yes. That being said, we can do a lot for women if it's not at like below the pelvic floor. When that tissue is above the pelvic floor, we have some conservative approaches that are highly effective in treating those lower grade prolapses and supporting surgical outcomes if you choose to go that route. So we're going to look at the pelvic floor and say, is the pelvic floor supporting you as much as possible? Are your hips strong? Or is your core strong? All those types of things of basically looking, is your body promoting support to hold those organs up or is it not? So that's like pelvic floor that's where our brains go with muscles. Are the muscles helping to hold that in? A big thing though with that is less about the muscles and more about the abdominal canister and the pressure management. So when Megan talked about people like having chronic constipation or chronic coughs or chronic heavy lifting and whatnot, we want to look at, you don't have to have been having like a high level job to still have faulty mechanics that are contributing to your prolapse. But if you're holding your breath, if your core isn't involved, if your pelvic floor isn't helping out, and we're pressurizing that system, then it's going to give somewhere. And if you have a pelvic organ prolapse, then that is the place it's going to give. That's the point of weakness. Your body's going to find an area to relieve pressure, and that's where it's going to be. So we're going to highly recommend that we look at all these mechanics of what are your body mechanics and what's your breathing pattern? What's your core doing? How's your body working as a team or not working as a team? Because our body, it's amazing when we get these things on point, how our body can support it instead of contribute to the problem. And so then people aren't afraid to lift or they aren't afraid to bend over, whatever. That's a big thing. Megan also talked about avoiding constipation because we know that would just increase downward pressure on that tissue. Not only are you pushing poop out at that point, then you're also pushing vaginal tissue out. And that's not the goal when you have a prolapse. There's also things Megan hinted at earlier, something called a pessary. That's a little device. I don't even want to say device, but think of like a brace almost for your pelvic floor, a splint, a space occupying. There's different ones. Some of them occupy space. Some of them actually like go in and try to hold things up and support.
Like supportive device.
Yeah. And they're fitted. They need to be fitted. They aren't 100% custom. I'd kind of call them semi-custom in the sense that like you need the right size, you need the right shape. You might have to trial and error some because it's not a one size fits all by any means. And so that's something where someone who is trained, and many pelvic floor therapists are trained in that. I am not, Megan's not at this point in our careers, we're not, but there are people who are, and you just have to find someone who's really good at that. And there can be really, really good outcomes by using a device like that that is inserted. It doesn't have to be all the time. Some people wear it all the time. Some people just wear it for their workouts, or if they're on their feet a lot, or if it's certain times of the month, like Megan hinted at, of if people know their body and they know when they need that support the most, then those pessaries can be a huge game changer in letting people still do the activities they love without the symptoms of pressure there.
Yeah. I know. I always tell people, I'm like, if you had a knee injury and you were going to go walk at the zoo all day, you would have no issue putting a knee brace on to help support so that you feel better to make it through the zoo.
Yeah.
And it's very similar of like what a pessary is. Like Roxy said, you can take them in and out. There's nothing wrong with using one if you need to when you need it. Like maybe it's just you have an issue when you're on your feet all day and you know you're going to go to the zoo. They used to get kind of a bad rap and were uncomfortable. And now if you get the right size and the right one, and it used to just be that like OBGYNs or urogynecologists fit them. And then now recently it is within the scope of rehab providers to be able to, pelvic rehab providers, as long as they've done the training, to fit them. So it's really awesome. And I think that they're great. I think they're absolutely great. I would not have any hesitation.
Nope. Just recently, real quick, I had a patient though that had a lot of discomfort with the one that the one that she was issued. And she's actually going back, and we've been working on some of this stuff, and she has a lot of vaginal dryness and a lot of skin irritation. And so in like the tissue around it isn't healthy. So then to insert that hasn't been super comfortable anyway. And it's not the right size or the shape for her. So she's, had a bad experience, but now she's done a lot of work, and she's seen like there's a lot that can be done. She has a lot less fear around her prolapse. And now she's like going to circle back to it, and it's going to be really cool because she's optimistic about it. I'll let you know how that goes. But she was like, when she came in, she's like, I'm never doing one of those pessary things again. That was the worst experience of my life. Like that was literally one of the first things she told me. And now like her and her OB have had conversations just last week about like, let's circle back to that. The urologist had done it, and now she's going to go to OB, like just even having a different person try it, maybe a different technique, whatnot. So anyway, that's my little plug on pessaries. And then obviously surgical options are necessary in some cases. I think sometimes we jump to that. I think that in some cases that's the option that's given because in fact it will lift that tissue up. But what I would caution people on is if this prolapse isn't as severe as is necessary for a procedure like that, we have to ask, why is this happening in the first place? And if we surgically correct that, but we don't take away the fuel to the fire, we don't take away the contributing factors that's pushing that tissue down in the first place, there are some people that don't have great long-term outcomes with some of those procedures if it's done on one, maybe unnecessarily or prematurely, and two, not done in a way that the whole body supports the outcome. So that's why I really promote, like, if you're going to have that surgery done, let's still do some visits of pelvic floor rehab so that your body is as healthy as it can be. It supports that procedure for the long term, and you're confident about those outcomes, and we optimize that choice.
Yeah. Because I mean, if you go and decide to go the route of a surgery for prolapse, and let's say that you're also constipated and no one ever flags that, like, okay, well, we need to look at like, why are you constipated? And you go and you have that procedure, which then you're also under anesthesia and pain meds, which constipate you. So then you're constipated. You just had this surgery to help with fix this prolapse. And now you're going to increase your pressure because you're constipated. How many times can I say that word? That's where, like Roxy just said, it can be really important to see a pelvic floor therapist prior to, just to make sure that we have like all the pieces to the puzzle, like what is going on here. And the other thing too, and this is not necessarily having anything to do with surgery, is there are cases as well that I have had where somebody has so much pressure thinking they have a higher grade and they don't. And one of the reasons why they felt that way is they actually did have a prolapse, but on top of that prolapse, they actually had a lot of pelvic floor tension, and the pulling down feeling of the tension caused them to feel the feeling of like everything's falling out, and it was tension. And so we figured that out. We worked on that. We, along with all the other pieces and components of strengthening and breath work and coordination and all of that. And then she got really empowered because she was just like, she was on her job required her to be on her feet a lot. And she realized she's like, oh, and now instead of feeling that and getting scared, like, oh no, she's like, I just do some down training that she learned or some different techniques I taught her. And she's like, and it went away and then I'm fine. So that's where it just is very helpful to kind of work with somebody and get a full idea of what is playing into the symptoms that you're having from the prolapse. Or maybe it's not even the prolapse, it's why you're getting symptoms. So yeah, pretty cool stuff. Okay, so let's talk about like prevention and management, which we've kind of alluded to as we've been talking here. Obviously, we're going to do a lot of education on body mechanics and posture because of the way that the organs have shifted and the architecture has changed. There's different positions that are going to optimize you or different body mechanics and the way that you're lifting or breathing, that sort of thing. It's the pressure piece of it. And then obviously we're going to give exercise recommendations to help promote and optimize where you're at in your journey, and knowing that it's not that anything's necessarily off limits. It's just we want to figure out what can you do comfortably that's not causing, and then yeah, exercise recommendations if there's any sort of other pelvic floor treatments that we need to be doing, and then ongoing monitoring if we need to, of like check-ins to make sure that what program we gave you to start with and like once we've graduated you is still doing okay. And do we need to advance it? Do we need to change it? Like what other factors have been going on? But as far as the management piece of it, that's where pelvic floor therapists can really step in and really change your quality of life when you have a prolapse, and knowing that like surgery is not your only option, and we can change. I mean, even if you're borderline between a grade 2 and a grade 3, like we can make some substantial difference on how you are able to, move through your day. And I think that's really encouraging because often, I don't know, I think that we just get overlooked in what we are able to do. And because part of prolapse in and of itself, it goes back to that whole biopsychosocial approach to what we do. And that if we aren't treating the whole body and the whole person, then we're not going to see the outcomes that we want to see. Anything else with that, Roxy?
No, well said. Okay. We want you all to ask for help if you're experiencing symptoms. Don't settle. Don't think that this is normal or that that's just how life is. There's lots and lots of things we can do to change that and promote current symptoms to decrease and long-term quality of life, basically. And we want to also encourage you kind of along that, on that same line or that same breath, is to start early. Like, don't wait for it to be miserable. Don't wait for it to get unbearable or beyond what you feel comfortable just dealing with. And so if the earlier we can start that, the better long-term success you can have. And just remember that prolapse is a very manageable and treatable thing to be living with the right approach, with the right guidance, with the right strategies. And there's we just see it a lot in our practice. There's a lot of really good outcomes that come along with doing this the right way, looking thoroughly at it, not settling for a quick fix or not just stopping things we love, but rather advocating for ourselves and the quality of life and the types of activities that we want to be involved in rather than just starting to cut those things out.
Yeah. Because sometimes it's just a matter of like a few little adjustments, it's like kind of like when you go to the eye doctor and you got a new pair of glasses and they're kind of okay, but they're kind of not. And come to find out, you go in and you think you need a new prescription, but really they just need to adjust the temples and the nose piece so that it lines up where it was supposed to. This is like a long analogy. And so it turns out to be something really simple. And sometimes we see that in our field that, if someone's lifting heavy and we make a few different cues, then suddenly they're like, yep, I can lift now. And I'm not even noticing that I even have any pelvic pressure, which is so exciting and fun. And I just love that so much. And it can be as simple as like working with somebody and now they're able to go to the grocery store and pick up the bag of dog food and put their groceries in the car and do all that. And they say like, yep, didn't even notice it was there. So we want everybody to be educated and know, because there's so many people walking around with knowing they either don't know that they have prolapse, suspect they have prolapse, have been told they have prolapse, but don't somehow get to pelvic floor therapy. So hopefully if you have a friend, it's like that. What was that reel? It's like, tell your wives, tell your mamas, tell your spread the word.
Sounds great, Megan. We're going to keep this conversation going. Like our page. If you have questions, we've gotten some good questions in and we're excited to answer those. And so we're looking forward to some more Q&As. So we want to definitely answer all the burning questions that you have on your mind.
Yeah. Send us your questions through our Instagram, and real easy. You've listened to this, you just scroll down. There's like 5 stars there and you hit that last star to represent a 5. Give us a good rating and, help these little souls that are doing this little passion project. So another great evening chatting with you, Roxy. Until
Always.
Next time.
See you later.
Bye. Thank you so much for joining us this week on the Pelvis Project podcast. Help us continue the conversation by liking and sharing this episode with friends. And if you really want to do us a solid, leave us a review. If you'd like to follow us on social, check out the show notes for links. And remember, this week, take a deep breath and relax your pelvic floor.